So good morning, and today we'll start with the keyword review, pediatric anesthesia. Many keywords are not reviewed. This is not just limited to, please don't limit your studies to this. Read more. But the most important ones I've tried to cover. We'll just go through some definitions first. Prematurity is a child that's born or infant that's born less than 37 weeks of gestation. Postconceptual age is weeks of gestation plus weeks post-birth. So if a child is born at 40 weeks of gestation and is 4 weeks old today, the postconceptual age is around 44 weeks postconceptual age. A low birth weight infant is one that weighs less than 2,500 grams at birth. A very low birth weight infant is one that weighs less than 1,500 grams at birth. A child that's small for gestational age is one whose weight is less than the 10th percentile. And according to the CDC, the leading cause of infant mortality is prematurity and not birth defects. A few words on fetal circulation. Oxygenated blood comes from the umbilical vein, from the placenta to the umbilical vein, inferior vena cava, into the right atrium. From the right atrium, most of this blood is diverted into the left atrium, from left atrium to the left ventricle to the aorta. Now the deoxygenated blood from the upper part of the body goes through the superior vena cava into the right atrium. Most of this deoxygenated blood is diverted into the right ventricle, the pulmonary artery. 90% of the blood that comes out of the pulmonary artery is shunted through the Ductus arteriosus into the aorta. So you have a lot of mixture post Ductus arteriosus into the system. Sometimes in children, especially preterm infants or children who have unclosed Ductus arteriosus, make sure you have pulse ox measurements, both preductal and postductal. Preductal is the right upper extremity. Postductal is the other three extremities. What happens when the child's born? The umbilical cord is clamped. Clamping of the umbilical cord results in increased systemic vascular resistance. Along with that is the initiation of breath. So once a child initiates the breath, these fluid-filled alveoli is converted into an air-filled state, and that causes reduction in pulmonary vascular resistance. And then, as time goes on, there's constriction closure of the ductus arteriosus, secondary to oxygenation, and the increase in left atrial pressures secondary to the causes closure of the foramen ovale. If you have to sum it together, fetal circulation is a high pulmonary vascular resistance state along with low systemic vascular resistance state, and shunting of blood right to left through the patent foramen ovale and ductus arteriosus. Following aeration of the lungs, there's a dramatic decrease in pulmonary vascular resistance, increase in systemic vascular resistance by clamping of the umbilical cord. It's very simple. The ductus arteriosus usually closes secondary to increase in PaO2 following birth and initiation of respirations. Functional closure occurs within 3 hours after birth. The anatomical closure around 3 days after birth. There's normalization of the pulmonary vascular resistance around 24 hours after birth. So what happens if this is not closed? You give it some time, it might close. If it doesn't close, you can treat them medically by giving indomethacin or do a surgical ligation. Or you could do it through minimally invasive procedures like transcatheter device closures. What happens if you don't treat it? These children could develop pulmonary hypertension, possible congestive heart failure, and cardiac arrhythmias. But in a small subgroup of infants, you need to have an open ductus arteriosus, and those children are those that have defects like interrupted aortic arch, critical aortic stenosis, and hypoplastic left ventricle. These children are cyanotic at birth, and keeping this ductus patent is very important to maintain oxygenation of the rest of the body. The neonatal pulmonary circulation is extremely reactive, and over the course of this lecture, you'll hear these words: hypoxemia, hypercarbia, acidosis, hypothermia are all bad, and the reason they're bad is because they cause an increase in pulmonary vascular resistance or worsen pulmonary hypertension in these kids. The neonatal myocardium is immature at birth, and hence it is less compliant. And because of that, it has a limited ability to increase contractility, and the stroke volume is fixed. And because the stroke volume is fixed, the cardiac output is rate dependent to about 2 years of age. Just remember, in a normal volemic newborn, if you give them a fluid overload or a fluid bolus, you do not see a good increase in cardiac output. The increase is very limited. There's hardly any change. To meet the increased metabolic demand, the cardiac output compared to the body size is more than 2 times that of an adult. So the cardiac output in a newborn is about 350 ml per kilo per minute. It's around 200 ml per kilo per minute when they're 2 months of age. The young teenagers, it's about 150 ml per kilo per minute, and in adults, 70 to 75 ml per kilo per minute. The baroreflex activity in these newborn infants is impaired, is still being developed. So a 10% reduction in blood volume, especially when they bleed intraoperatively, will cause a 15 to 30% decrease in mean arterial pressures. So make sure that you don't let them bleed that much. Fill that volume back. Some normal blood gas values you need to know for your boards. One of them is the PaO2 of the umbilical artery. It's around 19. Umbilical vein is 31. First hour of birth or first hour after birth, the PaO2 is around 62. 24 hours after birth, around 68. And as they grow older, a child and an adult, it's 99. Some children have persistent pulmonary hypertension, and it's secondary to elevated pulmonary vascular resistance, which causes right to left shunting through the foramen ovale and also ductus arteriosus, resulting in systemic arterial hypoxemia. What happens or what causes this pulmonary hypertension? It could be primary with no recognized etiology. It could be secondary, and that results from diseases of the lungs like bronchopulmonary dysplasia, meconium aspiration, infections, pneumonias. Second common cause would be congenital diaphragmatic hernia. These children are usually born with increased pulmonary vascular resistance. And remember, acidosis, hypothermia, hypoxemia all cause an increase in pulmonary vascular resistance. Some of the mechanical factors are overinflation or underinflation of the lung when these children are being ventilated in the NICU or in the operating room, pulmonary hypoplasia for any reason, and congenital cardiac disease. Polycythemia is one of the other reasons that can cause increase in pulmonary vascular resistance, and sepsis. Treatment: improve oxygenation, minimize pulmonary vasoconstriction. You can give a trial of vasodilating agents like nitric oxide, tolazoline, or prostacyclin. Tolazoline is a alpha sympathetic blocker. Always maintain systemic blood pressure and perfusion in these infants. In patients who are refractory, the treatment would be ECMO, extracorporeal membrane oxygenation support. You could get a question or two, in measuring the normal developmental milestones in a child. Things to remember, the most important ones are: a child can lift its head up around 2 to 4 months of age, follow with a conjugate gaze around 4 months of age, sits around 7 months of age, walks around the first year of life, first birthday, first steps is what they say, and runs around 2 years of life. Pediatric airway is a little different from the adults. Remember, neonates or young infants are obligate nasal breathers till about 6 months of age. They also have narrow nasal passages. These kids have a relatively larger tongue compared to the size of the mouth, and their epiglottis is long, floppy, and pendulous. The occiput is larger, so when you have to intubate a child, you really don't need to have a donut for these kids to place their heads on. They may actually benefit from a small shoulder roll to align the airway. The glottic opening in a preterm infant is around the level of C3, C4 in term infants, and in adults around C5, C6. The larynx is definitely anterior, and the vocal cords are kind of anterior slanting compared to a transverse or a slightly posterior positioning in adults. The narrowest portion of the airway is the cricoid in a child up to the age of 10 years, and then in adults, the narrowest portion is the glottic opening itself. So if you can put an endotracheal tube through a glottic opening in an adult, you could, in a normal adult, that size should be good enough. But in infant, just because you could introduce a larger endotracheal tube through the glottic opening does not mean that's the right size for that infant. The ventilatory response to hypoxemia in a neonate is extremely transient, and this is followed by decrease in ventilation. Whereas in adults and older children, you'll see a much prolonged ventilatory drive and tachypnea in these children when they're exposed to hypoxemia. Hypermagnesemia. This can be seen in those neonates whose mothers have had or received magnesium, especially for treatment of preeclampsia. When you see this child who has hypermagnesemia, they are kind of floppy, sedated, and when you use muscle relaxants in these children, these muscle relaxants are highly potentiated. How do you treat them? Treat them with IV calcium. But remember, it's airway, breathing, circulation first, and then treat it with calcium ions. A child can lose heat very easily in the operating room, and the 4 main mechanisms are radiation, convection, conduction, and evaporation. The most important of the 4 is radiant heat loss. It accounts for about 50 to 65% of the reason why a child loses heat in the operating room. One of your questions could be, how would you increase or decrease heat loss in the operating room when you take a child into the operating room? Increase the ambient temperature should be your first goal. Why do these children lose heat in the operating room so quickly? It's because they have a much larger surface area to body weight ratio. They also lack insulating fat, have a flaccid open posture, whereas we adults tend to curl up and preserve heat. They also have an impaired thermoregulatory ability just because they're still growing and still being developed. And in preterm infants, the dermis is not well keratinized, so the skin is much thinner and they lose heat quicker. What do we do when we lose heat? We increase physical activity and thereby produce more heat. We shiver, but in children, they're going to be floppy laying on the bed, so there's no increased physical activity for these kids. And shivering does not occur till about 3 to 6 months of age, so they can't shiver and produce more heat. But instead, what do? Is non-shivering thermogenesis. And this occurs through the metabolism of brown fat, and to some extent, skeletal muscle, liver, brain, white fat, but it's mainly the brown fat. With the cold stress, there's norepinephrine production, and this results with brown fat metabolism. Along with that, it also causes peripheral vasoconstriction to conserve heat, but it doesn't stop there. It will also cause pulmonary vasoconstriction, and if these infants have foramen oil that's patent, ductus arteriosus that's patent, you could have a right to left shunt. You can inhibit this brown fat metabolism by doing a surgical sympathectomy or ganglionic and beta blockade. Few words on brown fat. It's about 2 to 6% of an infant's body weight, and it's mainly located between the scapula. A large part of it is also in the axilla, some amount in the mediastinum. They contain multinucleated cells with numerous mitochondria. Remember, these cells are highly specialized. They have abundant vascular supply and neural supply. And these innervations are primarily mediated by a beta sympathetic nervous system. Why are we concerned about temperature regulation of these kids in the operating room? It's not just the kids. The effects are also for adults. It causes delayed awakening, cardiac irritability. You see arrhythmias in these children. And the most common is in adults. When you are warming a patient post-bypass, during bypass, you see ventricular arrhythmias, and that's because the patient's cold. You can have respiratory depression from hypothermia. This increased pulmonary vascular resistance again. It comes again and again. This drug metabolism is altered and slowed. They have coagulation abnormalities. In older children and adults, shivering increases the oxygen consumption by 200 to 400%. We want to prevent that. And of course, there's a shift of the oxygen hemoglobin dissociation curve to the left. The respiratory function in a neonate, they have high oxygen consumption. It's about 6 ml per kilo per minute versus adults 3 to 4 ml per kilo per minute. They also have a high minute ventilation, high closing volumes, and these children have horizontal ribs and very compliant rib cage. We adults have a rigid chest wall, so our rib cage doesn't flop back when we exhale. Since the airway diameter is extremely small in neonates, a small increase or small changes in this mucous membrane of the airway causes a very high increase in the resistance to airflow. The alveoli is still growing in these children, and it, I think, continues to grow to 6 to 7 years of age. The functional residual capacity, it's a question that's been asked a couple times. In an awake, normal infant, it's no different from that of an adult when you compare it to the body weight. But under anesthesia, it dramatically decreases. The diaphragm, though, in children has fewer oxidative fatigue-resistant fibers, and hence they fatigue very quickly compared to us adults. If you look at this respiratory variable table, the most important take-home points are minute ventilation. It's about 200 to 260 ml per kilo per minute versus adults that have about 90 ml per kilo per minute. The alveolar ventilation is about 2 to 3 times higher in neonates compared to adults. Functional residual capacity, again, when you compare them ml per kilo, they're about the same. And the oxygen consumption, it's about 6 to 8 ml per kilo per minute in neonates, newborn kids, versus 3 to 4 ml per kilo per minute in adults. Now, why do children have a better inhalational induction compared to adults? That's because these children have high minute ventilation to functional residual capacity ratio, a higher cardiac output with an increased blood flow to vessel-rich organs like the brain, and hence they have a rapid inhalational inductions when you compare them to adults. A few things to remember is what happens when they have a right to left shunt. In these children, when you do an inhalational induction and they have right to left shunt, there is a slower inhalational induction, but an increased rate of IV induction. But if these kids have a left to right shunt, unless it's really huge, there's barely any increase in inhalational induction time. Now, a few words on MAC. The MAC requirements are highest around age of 6 months. It comes back to normal levels around 1 year of age. Malignant hyperthermia. It's a pharmacogenetic disease of skeletal muscle, and etiology lies in the ryanodine receptor gene mutation. You can also have some variations and degrees of penetration being different, but the main reason is the ryanodine receptor gene mutation. Any exposure to triggering agents like our volatile anesthetics or succinylcholine can result in activation of this ryanodine receptor, resulting in uncontrollable release of intracellular calciums in the skeletal muscle. The triggering agents again include any volatile agents and succinylcholine. The safe agents are nitrous oxide is safe, folks, in these patients. You can do nitrous oxide or use nitrous oxide to start IVs in these kids. Ketamine, propofol, benzodiazepines, xenon, non-depolarizing muscle relaxants are all safe to be used in these kids. It has a autosomal dominant pattern of inheritance. There's some amount of variable penetrance and expressivity, but that's less. Just because a person had a normal anesthetic with a triggering agent the first time doesn't mean that this patient won't have malignant hyperthermia the second time you induce. But 1/3 of the patients, the malignant hyperthermia is seen in second, third, or the fourth anesthetic. So just be aware of that. When you do a chromosomal analysis, these patients usually have this ryanodine receptor on the chromosome 19. The signs: increasing end-tidal CO2 in spite of increasing your ventilation. Make sure you compare and see what the minute ventilation of the patient is before you say the patient's end-tidal CO2 is 70, this is malignant hyperthermia. If your minute ventilation is low and your end-tidal CO2 is high, correct that ventilation first. If the child has truncal or total body rigidity, the chance that this patient has malignant hyperthermia is extremely high. If they have Masseter spasm or Trismus, it could be malignant hyperthermia, could be the earlier sign, but we don't know. These patients could have tachycardia, tachypnea. When you do a blood gas, they have mixed respiratory and metabolic acidosis. Hyperthermia could be a late sign in these patients, and if you check, they could also have myoglobinuria. Treatment: discontinue all triggering agents. Start dantrolene 2.5 milligrams per kilo. You give them IV every 5 to 10 minutes until symptoms subside, or you've given them about 10 milligrams per kilo. Hyperventilate, initiate cooling, start bicarb. 1 to 2 milliequivalents per kilo is usually the first dose that you'd give, and repeat it as necessary. Induce diuresis in these kids. Make sure that they're well hydrated. Give mannitol if necessary, and Lasix if necessary. Some of the diseases that are associated with malignant hyperthermia, there are only 3. Central core diseases, multi-mini core disease, and King-Denborough syndrome. These are the only 3 diseases that have been associated with malignant hyperthermia. One of the questions you may be asked in your in-training exam would be the occurrence of Trismus of Masseter spasm when you induce a patient with succinylcholine. So what do you do? Now, this could be an early sign of malignant hyperthermia in most patients. But if this patient continues to have or has limb rigidity or total body rigidity, turn off your agent, use a non-trigger agent, and treat with dantrolene. If it's an emergency procedure, continue the case with non-trigger anesthetics, evaluate these patients, give dantrolene if necessary. In all of these patients, check for an initial CK enzyme level, repeat it every 6 hours for 36 hours. If these patients have dark colored urine or cola colored urine, check for myoglobin levels, hydrate these kids to prevent kidney issues, and then you observe these children in the PACU or in the ICU for the next 24 hours at least. Could have a question on the halothane caffeine contracture test. This test has a 85% specificity and 95% sensitivity for the diagnosis of malignant hyperthermia susceptibility. This test is done in vitro. There are only 4 centers, I think, in the United States that do this test. So the person really has to go to the center, give a piece of their muscle to get tested. This muscle that's been given is exposed to either halothane or caffeine, and the response is measured by a device that measures the force of contraction of this muscle. A response to halothane or a response to low concentrations of caffeine is considered diagnostic for malignant hyperthermia. This is a chart for neonatal resuscitation. It's self-explanatory. I won't go through it, but please do go over it. So one of the things that you could be asked is oxygen, and should we use it for neonatal resuscitation? But before we go there, appearance itself is not enough to gauge what the infants or the newborns' PaO2 or the SpO2 is. Please make sure a pulse oximeter is put on these patients. You start resuscitation, these newborn children, with air first or a blended oxygen-air mixture, titrating oxygen concentration as needed. If you don't have oxygen blended capacity in a place that you're working, start with air first. But if the child is bradycardic, has a heart rate of less than 60, even after 90 seconds of resuscitation with air, go back to 100% FiO2 and then go down as necessary. You could have questions on APGAR. This is important. You probably have, usually every 2 or 3 years, they repeat it. Look at this chart and remember you'll need to give a number after history has been given in your question. Now the question you could get is how you treat or manage patients with meconium aspiration. One thing to remember or take home point is if the child is vigorous, don't do anything. Just clear secretions, keep the child warm, you don't have to worry. But if the child is not vigorous, has decreased respiratory effort, has poor muscle tone, and a heart rate is less than 100, do a direct laryngoscopy, intubate, suction the trachea immediately, and then do positive bag ventilation. If you cannot intubate for some reason, please use bag and mask ventilation and ventilate these children. Don't worry about the meconium being in the airways. Once you do that, of course, the remainder, continue to do the other resuscitative steps, include keep the patient dry, keep the patient warm, reposition if you have to, and administer oxygen as needed. A preterm infant, again, is one that's born prior to 37 weeks of gestation. There's some problems that are very peculiar to a preterm child, and that is respiratory distress, apnea, hypoglycemia, hypocalcemia, hypomagnesemia, and hyperbilirubinemia. Under anesthesia, these or post-anesthesia, they're prone for postoperative apnea bradycardia. These preterm infants are also prone for retinopathy of prematurity. Postoperative apnea, I think we went through these definitions, so I'll leave it there. But to define apnea, absence of breathing for 15 seconds or more, or if they start desaturating, you don't have to look at the amount of time the patient's been apneic. If they have less saturations, they are apneic. The risk factors for postoperative apnea is prematurity. the more preterm they are, the higher the incidence for postoperative apnea. Anemia is one of the independent risk factors. If these children have a history of apnea bradycardia, have multiple congenital anomalies, have bronchopulmonary dysplasia, all of these are increasing factors for risk factors for postoperative apnea when you take care of them in the operating room. Apnea can be central or obstructive. When you talk about postoperative apnea, it's usually central. Again, the etiology, like I said, is multifactorial. They have decreased ventilatory control, which is potentiated by our anesthetics, and they have very limited responsiveness to hypoxia and hypercarbia, and this, along with the exposure to anesthetics, worsens the response. Remember, the diaphragm has not yet developed the fatigue-resistant muscle, so they fatigue very quickly. Would our anesthetic choice decrease postoperative apnea? If you use just regional anesthesia, there is some benefit, but once you use sedation to complement the regional anesthesia, you take away the protectiveness of regional anesthesia. And studies have shown that spinal anesthesia without sedation decreases. It doesn't take away, but it definitely decreases the incidence of post-op apnea bradycardia in infants. How do you treat them? Just pinch them? No. Blow by oxygen, some stimulation. Some children may need to be intubated and ventilated. And if you've worked with Dr. Brown, he loves to use caffeine. Caffeine is one of the stimulants, and theophylline is also another stimulant. How do you monitor them post-op? If they're preterm, make sure that these children are monitored post-operatively until about 60 weeks post-conceptual age. They should be apnea-free for 12 hours, or you observe them overnight. The incidence is highest for postoperative apnea bradycardia within the first 4 to 6 hours after an anesthetic exposure. Full-term infants are prone for apnea bradycardia to about 46 to 48 weeks post-conceptual age. A few words on retinopathy of prematurity. It's also called retrolental fibroplasia. Infants are at risk till about 44 weeks post-conceptual age. How do you prevent them? Prevent prematurity. But when you have them in the operating room, you make sure that the PaO2 is around 50 to 70, and since you're not going to measure PaO2 levels, make sure that the saturations are in the upper 80s and lower 90s. And the reason is the oxygen tension of the retinal artery has been linked to the causative factor for retinopathy of prematurity. Congenital Long QT syndrome, I think this came in last year or the year before. These children have, with the congenital Long QT syndrome, have prolonged ventricular repolarization, and this is evidenced when you take a strip of their EKG and see it. They could have arrhythmias from this, and the arrhythmias are usually secondary to mutations in the cardiac ion channels. The most common presentation is torsades points, but they could also have ventricular fibrillation or bradyarrhythmias. These children could present with recurrent syncope, cardiac arrest, and seizure-like episodes, or even sudden death. How do you manage patients with QT syndrome who have torsades? In the acute phase, give IV magnesium. If that doesn't work, you can do cardioversion with 1 to 2 joules per kilo. To prevent this long term, these patients should be beta blocked and decrease the adrenergic stimulation when you take care of them in the operating room. And obviously, you avoid procainamide and amiodarone because that would worsen the block. Congenital diaphragmatic hernia. So we see about 3 to 4 a year in our hospital. Just remember, when you see the word scaphoid in your exam, think about congenital diaphragmatic hernia. When you look at a child that has a scaphoid belly, think of congenital diaphragmatic hernia. And what is it? It's herniation of the abdominal viscera through a defect in the diaphragm into the chest. They have a very high mortality. 50% of these kids die in utero or immediately after birth. The pathophysiology, they develop pulmonary hypoplasia, and that's secondary to the herniated gut in the chest, compresses the lung, and hence prevents normal lung development in utero. And because of these, the lungs have reduced bronchial size, they have less bronchial branching, and decreased alveolar surface. Compression and hypoplasia of the contralateral lung can also occur, and the degree of this hypoplasia of the contralateral lung depends on the amount of herniation into the chest. A classical triad for congenital diaphragmatic hernia is cyanosis, dyspnea, and an apparent dextrocardia, and that's because the gut's pushing the heart, and it's more a mechanical push than a real dextrocardia. When you examine them, like I said, they have scaphoid abdomen, a bulging chest, and when you listen, you hear decreased breath sounds, but you may hear bowel sounds in the chest. And when you take an x-ray, they have a bowel gas pattern in the chest, and depending on the herniated contents, you could also see a mediastinal shift. What's your first line of management? Decompress the stomach. The bigger the stomach, the more the compression of the already compressed lung. Avoid positive pressure ventilation just because you want to prevent bowel distension. Improve oxygenation. You may have to intubate these kids to increase oxygenation and also decrease the pulmonary vascular resistance. When you ventilate them or initiate mechanical ventilation, make sure that the peak inspiratory pressures is limited to less than 30 centimeters of water. Treat the acidosis, support perfusion, and decrease pulmonary vascular resistance. Complications, especially intraoperatively, you could see a pneumothorax, a tension pneumothorax, and this occurs on the contralateral side of the hernia. So if a patient has a left-sided congenital diaphragmatic hernia, you probably see a pneumothorax on the right side. Following surgery, most of these children do very well for the first day or so, and then they develop severe pulmonary hypertension and may need ECMO for support or may even die. The most important complication postoperatively is the persistence of this pulmonary hypertension. Few words on ocular cardiac reflex. It is a trigeminovagal reflex. The afferent pathway is the ciliary ganglion trigeminal nerve to the fourth ventricle, nucleus of the fourth ventricle. The efferent is through the vagal nerve. This is elicited by any pressure on the globe, the orbit, or traction on the extraocular muscles, especially the medial rectus, traction on the conjunctiva, traction on any orbital structures, performance of a retrobulbar block itself. Remember, hypercarbia, hypoxemia, and light anesthesia, all of them worsen or increase the severity of the ocular cardiac reflex. If you see a child who's bradycardic in the eye room, make sure that the child is not hypoxemic, is not hypercarbic, and is not light. The most common manifestation is sinus bradycardia, but you could also see junctional rhythm, AV block, ventricular bigeminy, and also asystole. How do you treat? Tell the surgeon to stop. Evaluate your depth. Evaluate the ventilatory status of your patient. And if it's persistent, use atropine glycopyrrolate. Just remember that repeated manipulation weakens this reflex. So they do it 3 or 4 times, the 5th time maybe there's no effect. A few words on retrobulbar block. When they place the retrobulbar block, because of the sudden increase in the volume and pressure in the ocular, in the orbit, it can cause ocular cardiac reflex. But once this block has set in, it actually prevents ocular cardiac reflex. I think we'll continue this tomorrow.